Hi students, and welcome to this lecture on spinal cord injury. Now, the learning outcomes that I want you to take from this particular lecture is to be able to explain the common etiology, so this is the cause associated with spinal cord injury. I also want to know the different classifications, so how do we class the degree of injury and the common clinical manifestations associated with spinal cord injury. All right, so let's get our bearings, let's get an understanding of the anatomy again of the spinal cord. So here we have the brain. We know that the brain is there to perceive what's happening in the body, but also to help the body do things. And the way it can communicate with the body is through this connection or this continuation of the brain called the spinal cord. So if the brain wants to move the body or tell glands to do something, it sends a motor signal down the spinal cord and out into the body via spinal nerves. Now, in a sensory context, how do we get information from the body back to the brain? Well, it comes in via spinal nerves again, but they're sensory. They come into the spinal cord and they travel up the spinal cord to the brain, and the brain makes sense of that information. So this is how it normally operates. But when we have a spinal cord injury, we then have some kind of disruption to those signals. Over here, I've got an image of the spinal cord in cross-section. And so this is going to help us understand the way that these signals move. But before we get ahead of ourselves, let's just get an idea of, firstly, the cause. So the at-risk groups, so these are the people who are most likely statistically to have spinal cord. The most common group are young men. Okay, and the etiology, so the causes within this group is motor vehicles accidents, so motorbike or car. It's very high, probably about 50% of this group is in that particular fashion, or particular sports like football, rugby league, etc. Water sports like diving into pools. The other cohort that is at high risk are the elderly. So how do the elderly get spinal cord injury? Well, it's usually through falls. So the falls cause damage to the spinal cord. Now, how do these injuries lead to a spinal cord injury? Well, depending on so if it was a motor vehicle accident where you, let's say, have a head-on, so you hit something with a lot of force, it can cause the head to go forward, and that is what we call a hyperflexion injury, and that would cause a significant amount of stretch to the spinal cord, and that can tear the spinal cord. Opposed to hyperflexion, it would be hyperextension injuries, so the head gets thrown back significantly. So this could be in football, or if you were to fall down the stairs, for instance, and it would do the same kind of thing as hyperflexion, but the head's going the opposite direction. Another cause would be compression injury. So this is where a lot of force gets put through the spinal cord from either above or below, and examples would be jumping into pools where you put compression injuries into the spinal cord. So these are some of the different etiologies. Now, if you were to have bone fragments, so along the spinal cord we know we have vertebra. So if the vertebra were to be fractured, and then these fracture pieces were to go into the spinal cord, that would cause also severing of the spinal cord. Other mechanisms of injury could be bullets or stab wounds that could also do something similar. Now, in terms of, so that's etiology, and that's the at-risk groups. How do we classify injury? Well, this takes us to what we call the ASIA score, which stands for the American Spinal Injury Association. And so this is basically grades the degree of injury, and we go from A, B, C, D, E. E essentially meaning no deficit really at all, A being the worst. So this would essentially be what we call a complete injury. What do I mean by that? Well, let's say you had an injury at the cervical level. A complete injury would mean the injury severs the spinal cord completely all the way across. So that means pretty much no motor going down, no sensory going up. So the person wouldn't be able to move the body below that injury and wouldn't be able to sense anything below that injury. So that would be complete. And as we move through the B's, C's, and D's, it would start to become incomplete, and there would be different levels of motor and sensory deficits. Okay, so that's the ASIA score, and that's essentially how we grade the degree of injury. The other way we can grade it is just the level of injury. As you would imagine, the higher up the injury, the more debilitating to the body. So cervical injuries, like we can see here, generally results in what we call tetraplegia or quadriplegia, which means you can't move both limbs. As we start to move down into the thoracic region, You may have paraplegia, so you better move and sense the upper limb, but not the lower limb. And as we start to get into the lumbar regions, we may be able to have some use of or feelings within the legs. There's a lecture that I've recorded in terms of levels of spinal cord injury, which you can refer to for a bit more information in that space. Now, the next thing I want to kind of go through are the clinical manifestations that occur with spinal cord injury. So let's just say that there was a spinal cord injury at the cervical level. In the early minutes to hours within this injury, as we know with all injury, we get significant amount of inflammation. So we have inflammation because we've got cell injury, and we know what happens with inflammation. We get lots of fluid, so we get lots of edema. Now, as a result of that, around the injury site, what we'd probably start to see is dysfunction completely through the whole cord. So even if you had injury, let me just remove this off, even if you were to have injury just at a certain area of the spinal cord, because we've got so much inflammation and so much edema, what we would actually see is probably a complete deficit in the early stages of that injury. And that's what we're going to call spinal shock. So in spinal shock, it's essentially neurogenic shock, which means the whole nervous system at, around, but also below the injury go into shock. That means it kind of doesn't work very well. And so this is the first stage I want you to be aware of after injury, spinal shock. And by and large, that is due to the inflammation and edema. So what that means, if you were to have a spinal cord injury, you generally would expect no function at and below the injury site. So if it was here at, let's say, C5, what we wouldn't see is any motor signals going down to the arms and legs. So we'd probably see complete quadriplegia at that point. We'd have no sensory information coming up because it can't get through this complete lesion. And we'd also have a deficit in reflexes. So there would be no reflexes at the location. I've also done a lecture on the injuries that impact motor nerves. So this would be reflexes. So have a look at that video just below this one, and that will kind of go through the differences in reflexes and muscle strength and muscle bulk, etc. But the take-home point, in the early stages of spinal shock, there wouldn't be any reflexes below the level of injury. So if you were to do a patellar reflex, bicipital reflex, or look at, say, bowel bladder, there would be none of that. We'd also see a quite low blood pressure. Now, over time, and with the treatment of medications, particularly steroids and anti-inflammatories, we may start to see the reduction in the inflammation and the edema. So we can start to take pressure off the spinal cord, which then would reverse that spinal shock. And what would it see post-injury, so kind of more long-lasting effects, is the deficit that is actually at the spinal cord. So as I said, if you were to have an injury, let's say here, and that was all, what we would probably see is only a residual effect from where the spinal cord has been damaged. So where I'm actually drawing here, this is the anterior, this is the posterior. Let's say this is the left, this is the right of the person. What we're seeing here is an injury site in the dorsal column on the left side. So we would probably see sensory deficits most notably in this person. So if it was here, we would probably see certain sensory deficits, any kind of region below that injury site. And when we say sensory deficits, because it's affecting the dorsal column, which is the fast traveling sensory axons, we're going to probably see loss of proprioception, fine touch, etc. But because pain is actually traveling in pain and temperatures traveling there, in spinothalamic, the patient's probably going to have feeling in terms of pain and temperature, so that will be okay. And because the motor is getting carried kind of in these regions, the motor may not be affected. So slowly after the spinal shock is going away, the person may start to get back some sensory and motor function below that level of injury. Okay, but it really depends on the degree of injury and effect within the spinal cord on how much they will get back, and that's based on that ASIA score. All right, the last thing I want to talk about is what we call autonomic dysreflexia. So this is a medical emergency if this occurs, and it usually is where we have spinal cord injury in the thoracic region. Okay, so autonomic refers to the autonomic nervous system. Dysreflexia means it's disordered the way it controls itself. Now, so the way this happens is you generally will have a spinal cord injury around the level of T6, and what it's impacting is what we call the sympathetic nervous system. We know the sympathetic nervous system travels from T1 to T12, so it's kind of in this region. So what happens to these people with a spinal cord injury around T6 is, after they've recovered somewhat and they've regained some function and some sensory input, a certain event occurs where we have a noxious stimulus below the level of injury. So noxious stimulus could be very restrictive clothing, so very tight socks, tight shoes, tight belts. They may not feel this because they've got spinal cord injury and they can't feel below that, but there is a noxious injury occurring in that area. It could also occur from pressure areas or overfull bladder or bowel impaction. But in any case, this noxious stimulus is getting carried up the spinal cord, because the spinal nerves are still normal. But because we've got a spinal cord injury, they can't go up past that for the brain to make sense of. So the person can't perceive these noxious stimulus. But what actually happens is, through a reflex, this noxious stimulus goes out into the sympathetic chain or the sympathetic ganglion of the sympathetic nervous system around the T6 level and goes out into these ganglion. And what they do is activate the sympathetic nervous system. And you know that sympathetic nervous system is fight and flight. So what's one of the first things it does below the level is cause a significant vasoconstriction. Now, a response, if you vasoconstrict throughout the body, what that's going to cause is a massive increase in blood pressure. So blood pressure starts to go through the roof. So this is usually an indication that autonomic dysreflexia is occurring. So if you're caring for a person with spinal cord injury and their blood pressure starts to become uncontrolled, going through the roof, that's an indication that there's probably some kind of noxious stimulus at the lower levels, at least below the level of injury. So blood pressure could go above 200 millimeters of mercury. Now, the body tries to compensate with that, and so the way it does this is anything above the injury, it tries to counter it. So it actually tells the body to slow down. So it tells the heart to slow down. So we see now bradycardia. But because we've done so much vasoconstriction and it's affecting above the body, above the injury as well, the person gets a big headache. So a really bad headache. They start to sweat above the injury. They get flushed. So their face goes red. Low heart rate, lots of sweating, blood pressure is really high. Below the area of injury, what we see down here is it stays pale and cool because we don't have an effect to do the counter effect of what we saw with the sympathetic nervous system. So basically everything above is activating the peripheral nervous system, everything below is the sympathetic nervous system. And this is essentially why it becomes an autonomic dysreflexia, because we're not able to organize and regulate the sympathetic parasympathetic response, and we have some real problems. And the blood pressure, the high blood pressure, is the medical emergency part. So that this has to be managed very quickly. Otherwise, the person could develop something like maybe a heart attack or stroke, things like that, because the body's put under so much pressure. So these are some of the clinical manifestation effects with more longer standing spinal cord injury. All right, so hopefully what we've seen is that you can now explain the common causes of spinal cord injury, how do we classify spinal cord injury, and the common clinical manifestations. Now, remember, they are based on where the injury at the cord level is occurring, so it not only depends on the level of injury, but whether it's complete, incomplete, and we go through stages where initially we have spinal shock, then we kind of resolve the shock, and we have the longer lasting effects depending on the degree of injury. But another important cause is the autonomic dysreflexia, which comes about when we have an injury at around level T6 and there's a noxious stimulus below that level of injury.